What is myocardial infarction? Myocardial infarction occurs when blood flow to a part of the heart muscle is blocked, causing damage or death of the heart tissue. This is a medical emergency and can be life-threatening if not treated promptly. Main cause of myocardial infarction. Atherosclerosis, most common cause. A buildup of plaque, fat, cholesterol, calcium, and other substances in the coronary arteries. Over time, plaques can rupture, leading to formation of a blood clot thrombus. This clot blocks blood flow to the heart muscle. Without oxygen, part of the myocardium, heart muscle, begins to die. This is the infarction. Other causes of MI, less common. 1. Coronary artery spasm. Temporary tightening of the coronary artery can reduce or completely stop blood flow. 2. Coronary embolism. A clot or debris from elsewhere in the body travels to and blocks a coronary artery. 3. Coronary dissection. Tearing of the inner wall of a coronary artery leading to obstruction. 4. Severe hypoxia. Conditions like severe anemia, shock, or respiratory failure can reduce oxygen delivery to the heart. Major risk factors. Smoking, high blood pressure, hypertension, high cholesterol, diabetes mellitus, obesity, sedentary lifestyle, family history of heart disease, excessive stress or alcohol use. Causes and risk factors. The primary risk factor for squamous cell lung carcinoma is tobacco smoking, with about 80 to 90% of cases linked to smoking. Other risk factors include exposure to secondhand smoke, occupational exposure to substances like asbestos, radon, and metal dust, air pollution, family history of lung cancer. Symptoms. Early stages of squamous cell lung cancer often present no symptoms. As the disease progresses, common symptoms may include persistent cough, coughing up blood, hemoptysis, shortness of breath, chest pain, hoarseness, unexplained weight loss, frequent respiratory infections. Squamous cell carcinoma originates from squamous epithelial cells that normally line the airways. These cells undergo malignant transformation due to chronic irritants like tobacco smoke, gross morphology, macroscopic features. Location. Typically centrally located, arising in the proximal bronchi, main or lobar bronchi, frequently involves the hilum or central portion of the lung. Appearance, firm, gray-white, and often lobulated mass. Frequently cavitated due to central necrosis, seen in up to 10-20% of cases. May cause obstruction of the bronchus, leading to distal atelectasis, or post-obstructive pneumonia. Invasion. May invade into adjacent lung parenchyma, blood vessels, pleura, or mediastinal structures. Microscopic morphology, histological features. Hence 1. Cellular characteristics. Polygonal cells with abundant eosinophilic pink staining, cytoplasm. Large hyperchromatic nuclei with prominent nucleoli. Intercellular bridges, desmosomes, between adjacent tumor cells. Variable mitotic activity, sometimes with atypical mitotic figures. 2. Keratinization. Keratin pearls, circular whorls of keratinized cells, classic feature. Individual cell keratinization, seen in moderately to well-differentiated tumors. 3. Tumor differentiation grades. Well-differentiated, prominent keratin pearls and intercellular bridges. Moderately differentiated, some keratinization, fewer keratin pearls. Poorly differentiated, little or no keratinization, may resemble other NSCLC types, needs IHC for confirmation. Immunophenotype. Used to confirm squamous lineage and differentiate from adenocarcinoma or small cell carcinoma. Positive. P40, most specific, P63. Cytokeratin 5/6, CK 5/6. Negative. TTF1, napsin A, differential diagnosis. Squamous cell carcinoma may resemble adenocarcinoma, particularly non-keratinizing SCC. Large cell carcinoma, poorly differentiated. Small cell carcinoma, when very poorly differentiated. IHC is often essential to confirm diagnosis in ambiguous cases. Diagnosis typically involves health +1, very well health +1, imaging tests such as chest x-rays and CT scans, bronchoscopy to visualize the airways, biopsy to obtain tissue samples for pathological examination. Biomarker testing, including PD-L1 expression levels, to guide treatment decisions. Staging. Squamous cell lung carcinoma is staged using the TNM system Longevity Foundation. +1. Healthline. +1. T. Tumor. Size and extent of the primary tumor. N. Nodes. Involvement of regional lymph nodes. M. Metastasis. Presence of distant metastasis. Stages range from I, localized, to IV, advanced, metastatic. Treatment options. Treatment depends on the stage of cancer and the patient's overall health. Surgery, lobectomy or pneumonectomy for early stage tumors. Radiation therapy, often used in conjunction with surgery or for patients who cannot undergo surgery. Chemotherapy, commonly platinum-based regimens. Immunotherapy, agents like pembrolizumab, Keytruda, for tumors expressing PD-L1. Targeted therapy, currently limited but under investigation in clinical trials. Prognosis. The prognosis varies based on the stage of diagnosis. Healthline, early stage I, higher survival rates with appropriate treatment. Advanced stage, 3 IV, lower survival rates. However, advancements in immunotherapy have improved outcomes. Prevention and outlook. Smoking cessation is the most effective preventive measure. Regular screenings and prompt attention to respiratory symptoms can lead to earlier detection and better outcomes.